Good afternoon. Good afternoon, and welcome to the DCRI Research Conference. Hope everyone had a good new year and ready to dig into some scholarly activities. And this is a great way to start things off with Scott Palmer, who is an associate professor of medicine in the divisions of pulmonary medicine and critical care. Scott did his undergraduate work at Oberlin College, a place known well to many of us from the Midwest, and then came to Duke University as a medical student, and fortunately for us, stayed to do his internship, his residency, and then his fellowship in pulmonary and critical care medicine. Scott currently is the scientific director for the lung transplantation program and also oversees the pulmonary component of research here at the Duke Clinical Research Institute. And I've asked him to present some of his work in transplantation, specifically the work around CMV and its prevention. So, Scott, welcome.
Thank you. Thanks for having me. It's really a pleasure to speak to everybody. It's such a diverse audience. I tried to make this talk incredibly diverse as well, but hopefully not scattered. So we're going to cover some clinical and translational research. And I do think this may be a nice model of how I'd like to see pulmonary grow. Maybe not so much the purely large clinical trials, but the translational component of this might be really a good model for where I'd like to see us go. So if I'm going to talk about lung transplant, I have to introduce the concept a little bit, and we're going to talk a little bit about lung transplant, something called bronchiolitis obliterans syndrome, which is a clinical condition that most patients end up dying of after transplant. We're going to talk about cytomegalovirus, which is a common opportunistic infection in transplant. And then we're going to ask a few critical questions. Is CMV related to or a risk factor for BOS? Can we prevent CMV? And even beyond that, can we perform some sort of translational immune monitoring to better understand who's at risk for CMV? And then I'm just going to highlight what we've done in perspective with some of the other things that are going on in pulmonary research at the DCRI. So lung transplant is still a relatively new intervention. You're at Duke, and Duke is one of the largest lung transplant programs in the world, but it turns out this is still relatively new. Although the first transplant was done in 1963, it really wasn't until almost 1990 that there was any appreciable volume of lung transplants in the world. And this is a fascinating story. The first lung transplant was done, we could spend an hour on this, was done by Dr. Hardy in Mississippi. And the first recipient was a prisoner who graciously volunteered to undergo that lung transplant operation. And it was published in JAMA, and there's a whole spiel about how high moral and ethical standards were applied to encourage this prisoner to volunteer. And unfortunately, he only lived about 14 days and didn't do well. And most transplants didn't do well for some time. But by the late 1980s, there really seemed to be at least enough success to get patients through the operation and through the first year. But lungs, unlike the other organs, have a lot of complications, higher rates of rejection, higher rates of infection, and really relatively poor overall survival, even today, with a median survival only about 5 years. And there are a couple reasons for that. One of them, I think, is purely biological. There are things about lungs that are different than kidneys, livers, and hearts. Lungs are exposed to the environment. There's this constant interplay between what we breathe in, infections, toxins, and then the innate defenses we have in our lungs that deal with that. Those defenses may work great to get us over the colds we had over the holidays, but maybe not so great if you have somebody else's lungs inside you. And then there are clinical reasons. There's been a real lack of clinical research to define best practices in lung transplant. In fact, this counts as a disclosure. There are absolutely 0 FDA-approved medications for use in lung transplant. So everything I'm talking about is off-label. What happens is drugs get studied and applied in kidney transplant or heart transplant and trickle down. But there really has been not a lot of interest in developing drugs primarily for lung transplant. Now, despite all of those limitations, believe it or not, lungs are the only organ experiencing growth in national volumes. And for many patients with end-stage lung disease, because of a lack of any available medical therapies, lung transplant is really the only viable option. So this shows you what I kind of said in words. This shows you graphically that There was almost non-existent transplant volume in the 1980s. And then there was almost an exponential growth in the volume of lung transplant through the 90s, plateaued off around 2000. And we've started to see this exponential growth again, where this is up through 2007. More recent data suggests we're up over 3,000 transplants a year now. The two purple colors, the dark purple and the light purple is bilateral. And so one interesting thing about lung transplant as compared to hearts or other organs is you can transplant one or both lungs. And there are some diseases, like diseases with infection, where we think it's really important to transplant both lungs. There are other diseases like pulmonary fibrosis where you could only transplant one lung. But what we've seen is because bilateral lungs carry a better long-term survival, the growth has really been in doing more bilateral transplants. And there are some really interesting papers that have been published on that. We won't get into it much. This just shows you that if we look by ER, survival has been improving. So 1988 to 1994, 1995 to 99, and 2000, this is 1 year survival after transplant. It's getting better. It's about 85% at most centers now. But the thing that hasn't changed is the slope of this curve here. Long-term survival remains really poor. These things that I talked about, CMV and bronchiolitis, are still real problems. And I just wanted to show you, when I talk about bronchiolitis obliterans, it's a really unusual pulmonary pathology that these patients get and often end up dying of. This is an open lung biopsy. This is the edge of a vessel, so this would be filled with blood, a rather large vessel. And this would be an adjacent airway, sort of a bronchiole, a medium-sized airway. It should be open, widely patent, like a straw. But instead, it's filled in with all of this fibrosis. And the epithelium, or the lining cells that should be out here, are all kind of smushed in. So instead of breathing through this wide open airway like that, this patient's breathing through this tiny little space there. And not surprisingly, they have airflow obstruction on pulmonary function tests. And that's this thing called bronchiolitis obliterans. It's sort of interesting because the alveolar spaces are relatively well preserved. The vessel is well preserved. It's a histopathological entity, and it's also a clinical syndrome. And what we might see after transplant is a patient may have some ups and downs in their lung function. They might go on for a number of years and enjoy excellent lung function, and really have a drop-off when this kicks in. And it's primarily thought to be due to prior rejection, but more recently, the role of opportunistic infections has gotten a lot of interest. And in fact, CMV is one in particular. So CMV is a common infection in the population. Probably 85% of the people in this room have been exposed to CMV. It may have caused a diarrhea illness as a child or other kinds of childhood illness. In the setting of transplant, it can be an opportunist. We have impaired host defense, immune suppression, and you can either get CMV reactivating in a recipient, or potentially even worse, in a recipient who's never seen it before, transmit it from the donor. And CMV in transplant can cause a viral syndrome or organ-specific disease. There can also be asymptomatic viral replication. So CMV is a common opportunistic infection in transplant. In lung transplant, it can often cause pneumonia with these infiltrates. These are smudgy viral inclusions, and people can get very sick and even die from that. But we now have some treatments for CMV. We have ganciclovir. And so even if we have treatments, though, it still may be very important to understand, does CMV increase the risk for this bronchiolitis obliterans syndrome, this chronic condition that I said most patients are dying of? And there's actually been a lot of research in transplant about this, if we want to call it research. These are relatively small studies. Like I said, the interest lately has been in how infectious and non-infectious complications might contribute to the development of this condition of BOS, along with prior acute rejection. And CMV is the one that's really stood out. So in this slide, I highlight a number of studies that were done, essentially all the studies that were done up to 2002 in the transplant literature, looking at, is CMV a risk factor for bronchiolitis obliterans syndrome? And there were a lot of problems with these kinds of studies. These studies were small. Many times they only had a few cases with CMV. Many of them only did univariate analysis. BOS is a time-dependent outcome. It happens after transplant, and it's more likely to happen the longer you live. But many of the early studies just compared cases and controls and didn't really adjust for the differences in follow-up time. So there wasn't a lot of good literature, although there was a sense from some of these studies that maybe CMV is a risk for BOS. This Australian group probably published what became the defining paper. And interestingly, they came to the conclusion that treated CMV pneumonia is not a risk factor for BOS. And what they did was they looked in a single-center registry, and they focused on CMV pneumonia. I mentioned you could have syndrome or viremia, but they focused on a pretty good hard endpoint of pneumonia. And they correctly modeled BOS as a time-dependent outcome. And interest in CMV kind of waned after this. That's right about the time I got interested in CMV. The problems with this study were they looked at lung and heart-lung patients over a 14-year period, and there were a lot of there's variation in how they defined CMV, how it was prevented, treatment, prevention strategies over this time. This CMV pneumonia was subjectively assessed. And unfortunately, although they got the time-dependent outcome right, they didn't get the time-dependent predictor part of the model right, because CMV also happens over time. And so they didn't really model that probably the way they should have. So we went ahead and decided we would look at our experience with CMV in our single-center database. And what we found was that when we looked at 231 consecutive lung transplant patients here at Duke who had fairly long follow-up, and all of them, one of the strengths of what we did was all of our lung biopsies get prospectively stained for CMV. We ended up looking at over 1,800 biopsies and almost 7,000 PFTs and identified 21% of the patients that had CMV. We looked at CMV both fixed in time over the first 6 months as a risk for BOS over the subsequent time period or as a time-dependent predictor for the time-dependent outcome of BOS. And using both these approaches, we got very similar results. And showed that CMV pneumonia definitely increased the risk for BOS. And in fact, it actually increased the risk for death. And then we adjusted for other variables, and I think kind of set the record straight. We published in the same journal, our top-tier pulmonary journal, as that other paper, so it was kind of interesting. I'm still afraid to bump into the guy that published the first paper at the meetings, but he's a good-spirited Australian. I think he'll take it well. And this just shows when we looked at CMV fixed over the first 6 months and then looked at the risk for BOS after that point in time, freedom from CMV predicted a greater freedom from BOS as compared to if you got CMV pneumonia and actually predicted better long-term survival. So we really convinced ourselves that CMV is a bad thing in transplant using this sort of single-center registry analysis. And then we asked ourselves, well, if it's a bad thing, can we prevent it? And how do people do that? And again, there's no primary data in lung transplant, and there's no randomized studies out there. But the convention had been once ganciclovir became available, which is an antiviral drug that works against CMV, people started giving early post-op patients short courses of ganciclovir. And that generally worked to delay CMV, but despite that approach, about 50% of the at-risk patients still developed CMV. There are probably a number of reasons people didn't give longer prophylaxis. One of them was initially we only had IV ganciclovir, and it really wasn't feasible to put people on years and years of IV medication. But there was also concerns that you may not only delay disease, but you might breed resistance or cause more toxicity. But I was very interested in the idea that maybe that first year after transplant is really a critical period, and that if the reason we're reactivating our CMV is because you're immune suppressed and there's intense immune suppression early after transplant, maybe if we prophylax out through the first 12 months, that may be a much more effective strategy than 3 months of prophylaxis. And that beyond that time, your risk would be low enough that we could safely discontinue medication. And so we conducted a prospective randomized multi-center double-blind placebo-controlled study, which I'll refer to as the ValGAN study, to address exactly that question. And there are a number of challenges to doing this. As I alluded to, there's absolutely no existing lung transplant research networks. Among all the centers, there were fairly divergent and dogmatic opinions about what should be done. And of course, there wasn't really any funding. So these were all real practical challenges. This, fortunately, kind of fell into our lap because Roche developed valganciclovir, which was a highly bioavailable form of ganciclovir, thinking they were going to use it to treat CMV retinitis, treat CMV retinitis in HIV patients. But because of triple therapy and the effectiveness of triple therapy, the rates of CMV retinitis became relatively low, and it was less of an issue. So they were really looking for other markets, and kind of got interested in the idea that transplant may be a good market because CMV is a big problem in transplant. So the way the study went was we enrolled patients at the time of transplant. They received 2 weeks or less of IV ganciclovir, and then extended on to oral valganciclovir over the first 3 months, so that everybody got the same thing over the first 3 months. They got a short course of IV ganciclovir as soon as they were able to take PO medications. They got oral valganciclovir, and then at 3 months, they were randomized in a double-blind manner to either placebo or extended valganciclovir. And then we included a follow-up, and this is through 18 months, to look at issues like late-onset disease. And it was a pretty, I guess, well-done study, as well as things can go in lung transplant. We ended up with about 10 centers. We screened about 190 patients. We enrolled about 157. We randomized 136 that made it to 3 months. There were a few dropouts before the 3 months due to adverse events or other reasons. There were about equal numbers randomized in each group. About equal numbers dropped out, and about equal numbers completed the study. And we published this just recently in the Annals of Internal Medicine. What we showed was that extending prophylaxis to 12 months as compared to short course led to a really significant reduction in CMV disease. And I'm not going to get into all the details, but disease is really tissue-invasive disease like that pneumonia, 32% versus 4%. That's shown here. This is the probability of CMV disease or syndrome from the time of randomization onward. And we can see rather quickly the short course patients developed it. The extended course patients almost never did. We also looked at CMV infection, which is a more broad way of almost saying just any CMV virus detected in your blood. You don't have pneumonia, but maybe there's a little bit of viral replication going on. And that also happened to a much greater extent in the short course than the extended course. Safety was comparable. A really interesting component of this study was we collaborated with a guy, Ajit Lemay, at the University of Seattle in Washington, who's a CMV expert, and every single positive PCR CMV isolate was then genotyped for ganciclovir resistance mutations. And so we showed there was no difference. It was actually rather infrequent in either of these groups, in either arm, to see ganciclovir resistance. And that's important because one of the concerns, or at least a theoretical concern about extending prophylaxis, was that we might be breeding resistance. I think some of that had more to do with underdosing when people started using oral ganciclovir forms. And that may have contributed to resistance. But if we dosed appropriately, I think that's a non-issue. And we really didn't see late-onset disease. So that would really support the idea that this first year is a critical period over which you need to prophylax people. So are we done there, or is there more to the story? And I think we're not done. I think even though we know that 12 months is better than 3 months, I just showed you that there are problems on both ends of that. If we look back here, one could argue, well, 3 months didn't work so well for these people that developed CMV disease, but it worked fine for the people that never got it. And similarly, even 12 months wasn't enough in some people who still went on to get disease. So I was interested in better understanding, almost at an individual patient level, the risk for CMV disease. And we'll just step back a second and think about CMV-specific immunity. So we all have T cells that keep CMV in check and prevent viral reactivation amongst the healthy individuals here in the room. The question is, can we measure that? And if so, then potentially we don't need to have this whole 3-month versus 12-month fixed duration idea. We could potentially individually tailor therapy based on your risk at a particular time post-transplant. And this is a very collaborative project. Larry Snyder is a junior faculty in pulmonary. Kent Weinhold and his core laboratory in immune monitoring as part of the DTMI. And Cliburn is an MD PhD who does bioinformatics with Kent. And some of the data I'm going to present to you was actually funded by the DTMI core voucher funding to Larry Snyder. And then some of the studies I'm going to talk about that we're just starting are funded through this newly created biomarker factory mechanism to me and our group. So if we have this incredible T-cell diversity, we have greater than 10 to the 15 different T-cell antigen-specific epitopes we can recognize because our T-cells go through this VDJ, this gene rearrangement, to generate this incredible combinatorial diversity. So how do we pick out the ones that are CMV-specific among this 10 to the 15 different T-cells? Well, when CMV infects someone, it's presented in the context of self-MHC. So if this is an MHC molecule or a major histocompatibility molecule, CMV peptides are presented in the groove of that, and that's what's recognized by a T-cell. And they're immunodominant or key regions or key peptides, this IE1 and PP65, that are often what the immune system is responding to. So there are now libraries that have been developed of these regions that step across different stretches of those peptides and mimic what it would be like to present that in the context of self-MHC to allow us to actually measure CMV-specific T cells. And this is something that Kent's thought a lot about, although not in the context of CMV and transplant. Kent's thought about it in the context of HIV and vaccines and measuring efficacy of vaccines. And Kent, I already mentioned, has this good laboratory practice compliant immune monitoring lab. So we wanted to collaborate with Kent using some of his established techniques and protocols to apply CMV immune monitoring to our lung transplant recipients. And I'm going to show you some data where we look at flow cytometry graphs. I hope I don't scare anybody off. Nobody run away. We're going to follow SEB is a staph superantigen enterotoxin that stimulates nonspecifically, let's say. Media is a control. And then our CMV, our two different CMV peptides. When we do these assays, we use co-stimulation to help activate the T cells. We co-culture a patient's blood with a positive control, a negative control, and the CMV antigens of interest. And Kent's really worked out some beautiful flow protocols to look at CD4, CD8, and not just a single cytokine response, but a polyfunctional response looking at multiple cytokines simultaneously. And this is actually work that's also impressed now in a top transplant journal, AJT. So when we think about flow data, flow is a process where you stain with antibodies and separate cells based on their scatter properties and their color properties based on the fluorochromes associated with the antibodies. And that's how we distinguish things like CD8 from CD4 cells. And just to make sure when I show these graphs, really think of them in 4 quadrants. And this quadrant is CD8, kind of yes. This quadrant is CD4, yes. This would be CD4 and CD8, yes, which there really shouldn't be any. And this would be negative. So one of the things we're going to be looking at is a cytokine, intracellular cytokines. This is interferon gamma, and this is side scatter. This is TNF, this is IL-2. So when I kind of highlight here, CD8 cells, well, they're not making much IL-2. CD4 cells, yes, they're making some IL-2. Both kinds of cells are making TNF. Maybe a little more interferon here on the CD8 cells is expected than CD4. So we did this in lung transplant patients now, and we were very interested in measuring their CMV-specific immunity. And this is really just a proof of concept slide. It's not meant to really, it's a little bit interesting. There's kind of an interesting thing I'll point out, but it's really meant to just illustrate we can do this. So here's a negative control. Here's interferon, and this is this axis is the CD8 cells. Among the CD3 cells, we're looking at CD8. So we're looking at CD8 T cell interferon production. Negative control, nothing. That's good. This is PP65 and IE1. Let's skip to this positive control, lots of activity. Okay. So now PP65 IE1. This is a patient on valganciclovir transplant patient. This is one not on valganciclovir. This is a normal. If we look at the PP65 interferon response among the CD8 cells, it's actually pretty comparable in our 2 transplant patients and our normal, non-transplant healthy control. Interestingly, though, the normal has a much greater IE1 response than either of our transplant patients. So this may be a picture of what the deficient CMV-specific immunity looks like in lung transplant. But we obviously need to look at that in a lot more patients and understand what that means clinically. But at least it shows that in collaboration with Kent, we've been able to successfully apply this approach to measure CMV-specific immunity in lung transplant. And we have found certain patterns that I just alluded to one of them. CD8 T cells that produce interferon gamma and TNF in response to PP65 are primarily what we see. And what we'd like to do is figure out through prospective studies where we correlate this translational immune monitoring data with the clinical context is can we predict a number of cells or a quality of the cells in terms of a cytokine production that might be linked to either future risk of CMV, that either identifies patients at higher risk or lower risk. I also wanted to mention what Cliburn is doing. Cliburn's, I mentioned the bioinformatics person working with us and with Kent. And I showed you the way flow is done is really subjective, actually. It's a series of yes-no gates. CD3, yes, no. CD4, yes, no. Interferon, yes, no. A lot of subgating. What Clyburn's idea, which I think is really quite neat, was, well, why can't we use all of the data simultaneously? And he's been applying these mixture models, looking at, in this case, 11, all the different colors were mixing together with those antibodies simultaneously. And this automates gating to probably provide us with more accurate and reliable identification of the populations. And it may help us identify this CMV immunity signature that we're interested in. And this is an example from one of his papers where he used this mixture modeling approach that I probably couldn't tell you any more about other than that it's a mixture model. But it's fun to talk with Cliburn because he's such a bright guy in terms of trying to understand that. So I've just covered sort of a long and somewhat convoluted lung transplant story as it relates to CMV. But I think it's a neat story because it has a bunch of different parts to it. So starting with maybe a registry database analysis, we showed you that a single episode of CMV pneumonitis is associated with BOS and worse survival. And then we conducted a multi-center clinical trial, and that was rather challenging in the lung transplant patient population. And we showed you that 12 months of prophylaxis with valganciclovir is more effective than 3 months, but it's not perfect. And we're probably over-treating some people and under-treating other people. And I've shown you at least a proof of concept that we might be able to actually measure an individual's CMV-specific immunity and then determine maybe through some sort of a translational clinical study when and if we should discontinue prophylaxis in an individual patient based on their individual risk. And I think that's kind of the model where I'd like to see us develop. I'd like to see us not only develop immune assays that predict CMV and lung transplant, honing in on the quality and the quantity of cells needed to prevent disease, and apply that to patient care. But remember that CMV is not just a problem in lung transplant, it's a problem in kidney, liver, hearts, and bone marrow transplant. And these sorts of approaches may be relevant to all those organs. And we're also interested in working with Kent to not just monitor CMV, but to think about this other component I talked about, bronchiolitis obliterans and rejection, and try and develop immune monitoring assays to do that. And it looks like we're going to be funded to do that through NHLBI in something called the Center for Advanced Diagnostic and Experimental Therapeutics Phase 1, which is otherwise known as CADET. And that funding will start in a few months. So I think this approach is neat and allows us to kind of be rather translational. What I wanted to end with was just highlighting that in addition to what I've been doing here with the DCRI and with the DTMI in terms of pulmonary research, there are other things going on, and there are reasons to get more interested in pulmonary. So just stepping back a bit, everyone kind of knows respiratory disease is an important glowing health problem. You may or may not know, hot off the CDC press, pulmonary has just knocked off stroke, and we are now the 3rd leading cause of death. So we're creeping up there. And it's pretty obvious why. It's because we have no treatments for respiratory disease. Everybody else is getting better at treating heart disease and stroke and doing a lot of good research and evidence. But we're not. And on top of that, there's 1 billion smokers right now in the world, 2/3 who are in China and India. So as we think about the globalization of the DTMI and the DCRI, there are huge opportunities with regards to respiratory research in these other countries. There's really never been a distinct pulmonary therapeutic area at the DCRI. Even the pretty slide right outside the door now doesn't have pulmonary. But it has a lot of other therapeutic areas. And it's really a shame. I think the pieces of the puzzle have been here, and we just haven't connected the dots. So I've been doing some work in lung transplant and CMV prevention immunology. Kevin Anstrom really single-handedly has put together a really nice coordinating center that he leads for the IPF net. And IPF is idiopathic pulmonary fibrosis, another important lung disease that appears to be increasing in incidence and prevalence as our population ages. another disease for which we have no treatment. So there are these huge opportunities. This is just a summary of the IPF net that, again, Kevin's really done an amazing job sort of independently putting together and coordinating. And I think it's more than 22 centers now. But they've got a network that the NHLBI funds, and the DCRI through Kevin is the data coordinating center, looking at things like anticoagulant effectiveness, Imuran, N-acetylcysteine, and sildenafil in IPF. And the sildenafil study was just published in the England Journal of Medicine, so I really want to give props to Kevin for coordinating that and working on that project. Although the primary endpoint was improvement in 6-minute walk distance, it was negative. It was a very well done study, and there were some interesting trends that probably are going to get followed up with other studies by that group. So I think part of why I wanted to do research conference was just to emphasize that we're really trying to grow a distinct therapeutic area in pulmonary medicine and grow our reputation at the DCRI in doing respiratory research. I'd like to build it on a very translational model that leverages the strengths of the DTRI and the DTMI, because I think that's how we're going to get really the most funding and do the most interesting research and make the greatest contribution. I don't think respiratory disease is necessarily going to be built on 60,000 patient clinical trials worldwide, but we can sometimes make just as powerful a story if we think translationally. And if we look at, in addition to this cadet grant, I mentioned the other grants that we just put in through the DCRI have been very translational. Transplant Genetics Genomics Consortium. This may be, if we get this will be rather interesting. A lung stem cell regeneration coordinating center grant. It's really more of a basic translational research, but NHLBI is interested, I think, in having a coordinating center that can maybe have a vision to translate some of that into people, so we should be at least competitive for that. And part of what I want to do is connect the dots. There are a lot of really talented, smart people that are interested in pulmonary disease, and probably a lot of people I don't even know here that maybe have an interest in pulmonary disease. And, you know, if there are ways that we can grow collaborative opportunities within the DCRI or the DTMI, I'd really like to do that, and obviously continue to build on our relationships with industry. So I think, you know, I told you a CMV story, but I really hope that can be a translational model for how we can grow a variety of different kinds of pulmonary research projects. I wanted to thank all the people in my laboratory that worked on the research I presented, especially Laurie, who was first author on at least one or two of the papers that I presented to you. Certainly want to acknowledge all the people in the Immune Monitoring Core Laboratory, Kent. I want to thank Missy, who's in the front row, who made this Valgan study happen. Despite the many times we probably should have given up on it, we actually got it done. The other people that worked on that. I want to thank Ralph, who's been very supportive of me developing pulmonary as a therapeutic area. I didn't think to thank John, but when I started here, John was the director of infectious disease and was very nurturing and supportive with regards to our CMV work. And I also want to acknowledge Kevin and his IPF network and thank him for giving me some slides that I presented. I think that's it. Plenty of time for questions.
Thank you, Scott. I think it's a mixed blessing that you're now number 3 in overtaking stroke. It's clearly an opportunity and something that we have to take very seriously. A question.
In our allogeneic bone marrow transplant patients who had follow-on graft versus host disease, bronchiolitis obliterans, was also a very difficult problem. But the absolute death sentence in those people was if they continued to smoke. We found we could not rescue them in any way if they continued to smoke. Do you have any data on that? I'm sure people have to sign pledges and promise and everything. They'll never smoke again when they get their lung transplant. But we found that was just unrecoverable.
It makes sense. Fortunately, we do have a pretty good screening process. Everybody goes and sees a social worker or a psychologist, and we really have to be convinced somebody's not going to smoke again before we go ahead and offer them a transplant. They often have 6 months, a year, or longer where we'll say, no, we're not going to consider you. You need to be off tobacco products. We've even started doing some random cotinine testing. So there's probably a handful of people I can think of that have gone back to smoking out of the 1,000 transplants we've done. So we're pretty fortunate that it's a small enough number. I don't have a good anecdotal sense of, you know, they generally were not compliant and had a lot of other problems too. But the other part of your question, I think, is a really good point, which is that not only is CMV a problem in other solid organs and bone marrow transplant, but bronchiolitis obliterans in particular is a problem in chronic graft versus host disease after bone marrow transplant. And I think immunologically it's the same. It's host versus graft or graft versus host attacking the lung, and somehow that process of lung injury results in this odd, rare intraluminal fibrosis. And so we study in our animal models, we actually study pulmonary graft versus host disease because it's easier to get at some of those immunological questions than doing mouse lung transplants. I think the immunology is the same. And so if we find something that works for bronchiolitis in lungs, it's probably going to work in bone marrow transplant too.
Question and a comment. Question was, you first linked, you got us 3/4 of the way through the circle but didn't complete the circle. The idea that CMV might lead to bronchiolitis obliterans based on observational data, that we can prevent CMV. Where was the last step? That, in fact, you now have reduced the frequency of bronchiolitis obliterans?
Yeah, that's an excellent question. I was hoping somebody in the audience would ask that.
Give you that.
So I don't know if that's true. That is the last step. And to do the study and to power the study to answer that question was more than Roche was willing to fund at the time, because bronchiolitis obliterans is I mentioned, is a time-dependent outcome. So by about 5 years, about 50% of the patients will be affected. We followed patients through the first 18 months, and that was challenging to be able to do that. I think, in an ideal world, I would love to design a study now and say, here's our best strategy to prevent CMV and show that. In fact, that's what the New England Journal said. Maybe you were the New England Journal reviewer who said, we're not really interested in this paper unless you can show that full circle. And all I could do was hand waving and say, we're not going to have the resources to answer that question with this study, or with the study we did.
So the latter question would be that if you don't have the ability to do it within a large enough randomized clinical trial, why are you guys still dealing with a single center comparative registries? If you would just link your registries or link your hospitals among those centers, study exactly how you're treating these patients, you'd probably be able to show it regardless, right? You'd be able to show over time, I'm sure that now based on this publication, that in fact treatment patterns have shifted, and you should still see a reduction over time, I bet not as perfect as within a randomized study, plus generate all the other questions that you would like to do about how to better treat this disease.
Yeah, I think that probably is ultimately what will happen. So there is linked data. There's UNOS data and SSTR data. All of the centers that perform transplants, solid organ transplants, report their data to UNOS. It's a self-reported registry. There have been some really nice papers. There's a guy at Mayo that just had a JAMA paper about survival after lung transplant, the BO, using that registry data. So the data, there is some data there. The data is not very rich in terms of subtle things like CMV and how it was diagnosed, but it's very good for simple descriptive things like survival. And maybe one of the things one opportunity within our group at the DCRI and other people at the DCRI is thinking about that large registry data set and how we can ask the best questions of that data set, how to deal with the missingness and the self-reportedness and the challenges of the data. But despite those limitations, that's probably where we're going to go to answer some of the bigger questions. And I'm still hopeful that there will be industry interest in funding other kinds of studies where we can maybe weave in bronchiolitis as an endpoint, but it is challenging because it takes a long time to follow patients to get that outcome. But really good questions.
Infection with bronchiolitis obliterans is challenging. Just to name a few, back when I was dealing with a different kind of transplant, CMV was linked with rejection as a risk factor. And in addition, CMV commonly is accompanied by second infections. So those are just two come out at the top of my head. What are your thoughts about that?
So maybe to rephrase that, is CMV mediating directly BOS, or does it maybe indirectly, indirectly associated because it may increase acute rejection or increase other opportunistic infections? So we did at least look at that within the data set we had over the 18 months of patient data. And we didn't see an increase in acute rejection, and we saw comparable. So in other words, we saw similar rates by treatment group in terms of acute rejection and by opportunistic infections. The opportunistic infections is hard because when we do bronchs on people, we're always growing stuff out, and it's really hard to tease out what's colonization and what's infection with some of these pathogens. But my sense is that CMV may actually have direct immune effects that lead to BOS. Maybe it brings in T cells that then cross-react with the lung epithelium, or it does something directly. But we could also look at animal models where there are rejection models or BO models, like the tracheal transplant model, and they infect it with CMV and they get worse pathology. But it's a good question. You can't prove it. Certainly, all I've shown you is an association. I see another Oberlin graduate in the back. Wait.
So thanks, Scott, for a great overview of how you've put this pulmonary program together, and I'm glad to see you're putting your Oberlin degree to good use. I was surprised at Eric's question because there's actually another step to the circle, right, which is measuring use of ganciclovir or other similar antiviral agents as a quality indicator in lung transplant. And, it seems like that might be something that Roche would have some interest in. I don't know if the UNOS, I imagine the UNOS registry, for example, doesn't collect standard treatments that these patients get. But, thinking about ways to incorporate that kind of information into registries and watch for changes in practice patterns over time and the changing demographics then of CMV infection and maybe bronchiolitis obliterans.
Sure, it's a neat idea. I hadn't thought about that. Good.
Judy.
I was just thinking about the question that Eric asked and remembering a time when Eric used the Society, is he gone already? Is he there? The Society for Thoracic Surgeons registry to ask another question in the same setting where they didn't have enough granular data in the registry to directly answer what he wanted. And he actually got centers that were contributing to the registry to add some data. And you can sometimes take advantage, it's just a thought, you can take advantage of an existing structure to kind of add some collected data that then will allow you to use the structure to follow them longer term.
Good. Okay. That's a good thought.
I was struck when you began. You stated that the number of lung transplantations is increasing, unlike the other organs. You then went on to mention that there aren't any drugs that are specifically FDA approved. Is that because there's an assumption that all transplants are the same, that the anti-rejection drugs are identical, that these transplants are essentially one and the same? And if that's the case, is that true?
So that's a great question. I think it's right. My bias, obviously, is that lungs are different than kidneys. And in some versions of this talk, I have a giant picture of a lung and stick it next to a kidney and put a big not equal sign, because it's clear that the biology of the kidney, what rejection looks like in a kidney, what chronic rejection looks like, is different than in the lungs. And I alluded to the fact that the lungs have all of these different innate macrophages, alveolar macrophages, innate mechanisms that make me think it's not true. I think the cynical answer is, though, the industry just doesn't see as much of a market in lungs, and that if we're doing 16,000 kidney transplants a year and however many, 4,000 or 5,000 livers and hearts and 3,000 lungs, well, we're the smallest. And so if I'm going to do a clinical trial and get a broader market, it's going to be those 16,000 kidneys, and they've been doing them longer, and there's more of them. What I hope is that we, as the lung volumes are going up despite all of the bad things I told you about outcomes in lung transplants. So I hope that means maybe we can engage industry to actually do lung-specific trials or heart-specific or liver-specific in addition to the kidneys, and not just assume what I don't know if they really assume it or they don't necessarily care and they just want to make money, but that it's all just going to trickle down and the biology would be the same. But it really doesn't seem to be the case. I mean, the drugs right now, we're using the same drugs in lungs that they're using in kidneys. Similar drugs that have been shown in pretty good randomized studies in kidney transplant to be effective. And they'll be looking at about a 10% rate of acute rejection over the first year. And we're looking at a 50% rate of acute rejection with the same drugs. So that tells me the answer is no.
Absolutely. Good. Other questions or comments?
Were there gaps in your Valgan trial?
Yeah, a very small number, because I think in a way you could almost say it's conditional survival because you had to make it to 3 months to get randomized, and most of the deaths that happen are going to happen in their first 3 months. It was like 3 in one group and 4 in the other group over the first year among the patients we randomized at 3 months. So there's really no difference in survival.
This may be a dumb question, but do they screen organs for CMV?
No, it's actually a very good question. So in the old days, some centers would do that and would only take, like if I was a CMV negative person, they would intentionally pass on organs that were CMV positive, hoping to get a CMV negative organ. But that practice, that sort of didn't work out so well because people listed are often so sick and so critically ill, it's hard to keep passing on organs, and it's hard to find a CMV negative donor. So that practice, there was a time when, and there may even still be some centers in the world, small centers, where they do that. But most centers, because lungs have very short times between when you take them out of the cadaveric donor and you stick them in the recipient, we want that like 6 hours or less. And we're really not doing much screening at all. We're just basically saying, it looks like it's a lung and it works. Okay, great. But it's a good thought. And you know, the other question that nobody asked is about vaccinating the negative patients, and sometimes that comes up. And I think that would be another strategy, is if you could develop a vaccine that really worked and take those negative patients, or even the recipient positive patients, and somehow boost their immunity. And if we could actually use some of these techniques to measure that, that might be another strategy to reduce the overall burden of CMV.
I have a quick question. Thanks, Judy. How do we work backwards from clinical trials and registries to build your program? How do we develop sort of early translational strategies and collaborators above and beyond Kent Weinhold and the Immune Monitoring Corps, so that when you have an opportunity like this NHLBI study, you have a network, whether they're all Duke researchers or whether you use the CTSA network, for instance, to make sure that we're generating pipeline for pulmonary disease. It's a terrible problem that the pipeline is so bleak and that the epidemiology is so enormous. Right. But it seems like this is an incredibly good start, and I'm thrilled that DCRI is a home for you. But I'm grateful that we've offered you the biomarker factory and the IM core, but there's got to be more, and there have to. What are your thoughts on what that landscape is at Duke, and what we could do to sort of foster the development of a pipeline?
Yeah, I think it's a challenging question. So I think the way I would approach it is the same thing we've done here, which is identify people with unique talents and skill sets that can be brought to bear. Think of, looking across the country or even around the world at who are the people that are doing that preclinical basic research that we think is most likely to translate into something meaningful, and try and draw them, build relationships with them at an early stage and draw them in. We did that with this cadet grant. We have David Wilkes, who's at Indiana, and David's really been a rat lung transplant doctor most of his career, but he's made some interesting observations about a type of collagen and how autoimmune responses to collagen might underlie some lung disease. And he may be right, he may be completely wrong. But if he's right, then it implies there may be some very novel ways, like giving people oral collagen to develop tolerance as a strategy in transplant or IPF. And so I think that's one small reaching out kind of opportunity, but that could probably happen on a broader scale. If we really want to grow, that's the kind of thing we need to do. Because you're right, there's not a pipeline, but there are these academic pockets that may be resources we could draw into. It's challenging. It is kind of bleak. And I don't know if the DCRI is my home. We'll see after the talk how many people kick me out, and may not be any more.
All right, well, Scott, thanks so much for a terrific talk, and I would say that the vote would be you should stay.
I'm not.